Gerald here. Today I'd like to talk to you about the subjective examination and history taking in musculoskeletal practice. Most of us in physiotherapy have been taught a predetermined list of questions which we routinely ask patients in order to try to ascertain their functional difficulties and perhaps to try to categorize pathology. And in our evolving stage of development, these are often our high clinical priorities in order to try to see if we can match the story that the patients present with to our knowledge base, and therefore to be able to select appropriate treatment interventions as we have studied and learned. However, over the last decade, the whole evolution of integrating the psychosocial model into patient management has really meant that therapist skills need to have broadened out to a much broader base than is traditionally taught at an undergraduate level. Now, when the biopsychosocial model was popularized, it tended to coincide with the acknowledgement of multidisciplinary pain management clinics, and of course this way was appropriate in chronic pain management situations, but wasn't particularly relevant for acute pain management in a primary care setting. The model evolved so that the different disciplines essentially had a zone of demarcation in which their professional practice was consigned to. And again, in the tertiary care model of chronic pain and pain clinics, this model was reasonably effective. But to extrapolate that over a much broader population base, the idea of professional delineation is a much more challenging and really impractical concept. So this therefore then placed greater onus on therapists to actually identify elements of risk behaviour, elements of predictors of chronicity, elements of fear avoidance and distorted belief patterns that may profoundly influence the kind of treatment interventions that are undertaken and profoundly influence the prognosis. So therefore the onus of detecting these underlying mechanisms has now been placed firmly and squarely back in the clinician, whether it's a physiotherapist or any other primary care provider. Now, I've watched this debate evolve over many years, and it is my sincere belief that therapists are not particularly comfortable with this idea of exploring psychosocial issues. I think there are a number of reasons for it. I think we're not really taught these skills at an undergraduate level, for one. Two, I think there can be a refuge in hiding behind professional boundaries and therefore delegating our responsibility to psychotherapists or psychologists. There may of course be factors which are outside of our control, family issues, work-related behaviours, compensatory issues, which we need to know and identify, not necessarily because they are modifiable. In other words, they would fit into a category of unmodifiable variables, but we need to factor in those variables into our considerations of prognosis and in terms of being able to decide what type of intervention is appropriate or not, as the case may be. I think the other factor which is off-putting for therapists is that exploring these kind of psychosocial issues is very time consuming and it's quite draining on the therapist. So it does pose much more serious challenges than just simply working through a checklist of predetermined questions. But the converse of this is that it forms an absolutely essential cornerstone for establishing a proper patient-therapist relationship. And with that kind of trust and rapport established, it is much more conducive to delivering effective care, but also in terms of delivering prognoses which may not be as favourable for the patient as they may have initially assumed. So developing this type of rapport does allow a more accurate exchange of information. It also dictates how information is delivered, because depending on the patient's fear avoidance belief systems or how they interpret certain diagnoses, we can use different phraseology or different terminology to convey the same message without necessarily having the same implications for the patient. So our choice of words, the choice of phrases, our comparison of their symptoms to what we think is associated with the underlying pathology, these are all really important cues which patients pick up on, and we don't often have the luxury of being able to analyse in great detail what their interpretation of physical pain is. So we have to explore these things in terms of what it means for them. Have they seen other people in pain? Are they equating this symptom pattern with the beginning of something more catastrophic? They may have seen relatives with serious illness, with serious disabilities, and these are questions that are going through their mind. They may have felt that they're not getting a fair hearing from other professionals, so the chance to sit down and discuss their problems may be one of a high priority from their perspective. So these are all issues which we as clinicians face on a daily basis. But it's not simply an academic question, because understanding patients' belief systems and their interpretation of their problem and their expectations allows you to map out a process of care, allows you to establish milestones so that we can determine whether our initial hypothesis is actually materializing or whether some confounding variables have materialized which are actually going to influence or alter our prognosis. So this is a constantly dynamic, interactive process. So undoubtedly it's challenging for the therapist. It means we must constantly challenge our working hypothesis. We must constantly challenge whether our input is being effective or not. We must ask the question, well, if our input is not being effective, are there other alternatives that would achieve more? Or sometimes we have to grasp the nettle and say, look, this in reality is probably as good as your function is going to get with the pathology that you have. It also means that we're like jugglers. We're juggling many balls in the air. We're trying to juggle the subjective history to determine likely pathology. We're trying to interpret the clinical examination findings, and then we're adding another layer of complexity on top of this in which we have to process and interpret the other information. And whilst this is challenging and it's demanding, I think the overwhelming opinion is now that this is an essential component of clinical practice. So it raises the question then as to how do clinicians go about learning these skills. There are very few formalized courses on this topic, and probably if there were they wouldn't be particularly well attended. The key is listening to the right cues. Picking up cues in a subjective history is a key element in order to determine how do you react to that cue. Do you proceed to then challenge an inappropriate belief or an inappropriate comment, or do you store that information and come back to it a little bit later, so perhaps a flag of awareness has been raised but it's not an issue you choose to challenge directly? If a patient has a completely distorted belief system, then the question really is at the time of your subjective history, is that the most appropriate time to actually start to challenge this, or is it just again to flag it and say we'll come back to those details in a little bit later? If they have a misinformed or misguided belief about their dysfunction, and of course with the vast amount of information available on the internet these days, we get many experts coming in who have self-diagnosed, so often we have to actually deconstruct this and explain what, yes, some of their hypotheses were correct, and in fairness they may or may not contradict other medical advice that they've been given, but there are other elements which may or may not be appropriate. So this essentially establishes a rapport, but it also establishes a level of competence and credibility where you acknowledge that the patient has a definite capacity to evaluate their own symptoms, but you're bringing an external layer of judgment to this to help to try to rationalise the process, and of course to actually see whether you can offer some useful practical advice. So it really means that therapists need to be aware of cues, in the subjective history, and then have a strategy to determine whether they react to those cues immediately or whether they store them for future use at some point down the line. This also then dictates that if you are going to challenge distorted beliefs or behaviours, then you need to have a predetermined strategy as to how you might engage with that patient to change the process. Are you simply going to be abrupt and dismissive, in which case you certainly run the risk of threatening the therapist-patient behaviour or interaction, shall I say? Or are you going to take a more collaborative style of approach to see if you can bring somebody around into a different way of thinking? So the message from today's video really is that taking each individual in terms of their specific set of difficulties and functional limitations has always been a clinical priority, but we need to also consider the psychosocial processes and the belief systems, and we also need to take responsibility for addressing those if they are responsible for perpetuating a disability. So the message from today is to broaden our net, to broaden our horizon. Perhaps it's really to take up the challenge and acknowledge that psychosocial issues are part of any clinical management strategy, regardless of the discipline that you're in. And if this topic is of interest to you, check out our blog at physiodigest.com. We have lots of discussions on evidence-based practice and therapist interactions and clinical management strategies. Hope to see you there. Take care. Bye for now.